I'd like to introduce Dr. Rita McCracken, who uses she, her pronouns and has a MD PhD. She's an assistant professor and family physician at the UBC Department of Family Practice. She's also the scientific director of the Innovation Support Unit. Rita's research aims to change patterns of prescribing and deprescribing in order to better patient outcomes. Her other research work involves studying the family doctor shortage in BC. And now it's all yours, Rita.
Great. Thank you very much, Shauna. Welcome, everyone. We are simply overjoyed with the number of participants today. In fact, we got so many, we wondered if some of you were bots. But we are so happy that you appear to be humans, albeit just white names on blank screens for the majority of you. So I'm going to go ahead and get started. I'm really interested in your questions and your comments about the content as we go through. This is our third time through, and we found that people typing things in to the chat as it comes up for them has been a great way for us to just make the learning a little bit more relevant for the particular group that we have here. So I'll start off with a thank you to our webinar team, which includes Dr. Jano Klimas, Misha-Anna Hamilton, Shauna Narayan, and Dr. Malcolm McClure, and I will mention them again. I respectfully acknowledge that I'm speaking to you today as an uninvited visitor on the traditional and unceded territories of the Musqueam, Tsleil-Waututh, and Squamish people. And as a healthcare provider, I acknowledge the devastation that government-created residential schools and Indian hospitals have inflicted on the health and well-being of Indigenous people in the past and in this modern day. I'm trying to, as a white settler, try to understand my perspective in this huge problem that we have with anti-Indigenous and anti-Black racism within the healthcare system. And so I'm trying to make a little bit more of a meaningful shift around how I'm thinking and how I'm talking about it. I welcome any perspectives that people have as we're going forward today. I'll give you the standard College of Family Physicians requirements for a declaration of conflicts of interest. My PhD studies were in deprescribing and reducing polypharmacy for frail elders. As a result, I didn't have a lot of pharmaceutical companies beating a path to my door to give me money. And so it has been easy for me to maintain not having commercial interest. I do receive money for the research that I do from various places, including CIHR and some local research funders, for which I'm very grateful. I get paid for the work that I do from UBC as a salaried academic member of the faculty. And I also am a family physician in East Vancouver, providing full service in a fee-for-service clinic. I believe that every human has bias, and so I'm going to do my best to be clear with you about what my bias is, develop my understanding of when it's happening. I've taken that to the next level we submitted all of this material to the Independent Scientific Planning Committee by the College of Family Physicians of Canada, which has allowed us to offer CME credit for those who are interested. There will be a process at the end for you to get that CME credit. And I'm going to provide references for all statements of fact that I made. And if you hear me saying something that you think needs to be challenged, please do it. This is the way that we're able to move science forward. As I mentioned, we have received funding from CIHR. They have been very generous. They also ask us to clarify that the views that we are expressing do not necessarily represent the views of, say, CIHR. And we've also are very grateful for the education and in-kind support that we've gotten from the BC Centre on Substance Use. They're a fabulous partner that has made this work possible. We have, in addition, the Therapeutics Initiative and the Portrait, which you'll see mentioned in the content, is another collaborator. So the learning objectives, just to remind you, I know you probably saw these when you signed up, but the learning objectives are at the end of this for you to have clarity about what the definitions opioid naive and opioid sparing mean, to describe the quality of evidence for opioid analgesic use for non-cancer pain, and to assess the utility and limitations of risk prediction tools, and describe opioid sparing approaches that you might be able to use in your practice. You'll notice that on the screen, a poll has just gone up. We ask everybody who's participating just over the next few minutes, if you wouldn't mind answering these questions. It allows us to see who's here in our virtual room with us, but also for us to get an understanding of what you know before you came, and if our content actually helps you learn those things while we're here. Your responses are all 100% anonymous, so you don't need to worry that we won't share your marks because we won't know what marks belong to each individual. So we'll leave that up for I think about 5 minutes or so, and I'm just going to move it off my screen so it stops distracting me. And thank you for participating in that interactive component. Really importantly, so I told you what we're going to learn. I also want to be really clear about what it is that we are not going to be covering today. So we are not going to be able to adequately address non-pharmacological approaches to pain management or barriers to those therapies. For example, physiotherapy is an amazing intervention for low back pain. There is some really interesting evidence to discuss. We are not going to be discussing that here simply because that is outside of the scope of what we are trying to do. And we also are not going to talk about the fact that it's really hard to get your patients access to physiotherapy in British Columbia. We are not going to learn how to recognize and treat opioid use disorder, which is a really important level of prescribing knowledge that we should all aim to have. However, we are not going to do that here because that is not the condition that we're going to be discussing. We're also not going to be discussing safe supply or risk mitigation. Again, very important, especially in this pandemic context and with our opioid crisis. But we are not, that does not fall within this. We are not going to address tapering approaches for people receiving long-term opioid prescriptions. I'm happy to say that most of these topics that I've just mentioned, the BC Centre on Substance Use already has materials that you can access on their website, webinars that you can download. And myself and a few other members of our team are working on developing additional educational modules on those topics. Another absolutely important element is to say, I am not talking, and nothing that we talk about here today has to do with palliative patients or cancer patients. So none of what we discuss today should be applied to people who are near the end of their life or who have cancer-related pain. So I just say that out there to be extremely clear about that. So, Shauna mentioned at the beginning that this is part of a research project. I'm sure many of you have been to lots of CME courses, and sometimes you're like, oh, that was pretty good. Oh, that wasn't very good. And you've probably also noticed that the format hasn't really changed much. We went from kind of a typical format before the pandemic, then we moved to a virtual version of that same format. We are very, very interested in understanding what aspects of this educational intervention that we are presenting to you today work and what doesn't work. And we're having a focus group that is going to follow this session, this webinar immediately. It will be 30 to 45 minutes long. We'll pay you $100 for your time in the form of a gift card. Shauna, if you would make sure that we put the link to the consent form. The only thing that you need to do is you need to review one of those hideous research required consent forms, which says that you understand that you're giving your information and that some of the content that we discuss might raise up some feelings for you. And we have noted some places where you could go for support if you had those feelings during the focus group. So thank you very much for my plug for the research component. We're going to start with a clinical scenario. A patient, Ms. M. So she's a 48-year-old lawyer, single mom, 2 elementary school aged kids. She presents to her family physician with bad elbow pain after a foosh fall a week ago. When she had the fall, she went to emerge. They saw with appropriate imaging that she had a minimally displaced proximal radius fracture. She declined an opioid prescription that was offered to her at that time because she needed to keep her head clear to deal with the kids. And so she's in your office now. Her pain is less than at the time of injury, and she's been getting some benefit from the NSAIDs and acetaminophen that the Emerge doc suggested that she used. But honestly, her sleep is completely disrupted. Typing all day is difficult, and at the end of the day, her arm is too painful to take care of any of her housework. So she's come to you today wondering, should I have taken that opioid? And will it help me now today? So let's discuss. How can we help this patient? I'm sure all of us have seen a patient like this, and we would love to offer unicorns and rainbows, right? Single moms who are working in addition to inside the house, outside the house are one of my groups of heroes. And I would love to be able to help them in any meaningful way that I can. But we have very little as doctors, as we know, we all know this. We have little that we can offer that works. And even the concept of what works is really important for us to keep in mind as we're considering how we're going to help this patient. So just a little bit of a diversion here. How will we know if this drug will work for her? She wants to know, will the opioid work and help me get back to doing the things that I want to do? A reminder that very, very few drugs have even a 50% chance of working, in quotation marks, for the patient in front of you. And working means the outcome that was studied, it actually happening in that patient. So that would be an NNT of 2. And certainly this is not well under, I know I sometimes forget this when I'm re-prescribing medications to patients that they should take, whether it's working or not, we don't know. And when you try to explain to a patient that I want you to take this medication, but I'm not sure if it's going to work for you, it can be really difficult for them to understand. And so just as a reminder to kind of put this in the context of primary care here, some important NNTs. A general anesthetic for surgery, thank God, has an NNT of almost 1, right? We've probably all heard a story where it didn't work and the person woke up with an experience of awful pain. But in general, if you give somebody a general anesthetic, they're out. Rapid defibrillation for cardiac arrest that you have in a casino that has a automatic defibrillator, the number needed to treat is 2 to 3 for you to have a 30-day survival. Viagra for sexual intercourse being successful, the number needed to treat is 2 or 3. And then we jump down to my special area of focus during my PhD studies was hypertension treatment in people over the age of 70. And much to my sadness, I realized that a lot of the hypertension treatments that we do have a very high number needed to treat. And that can fluctuate. Honestly, I've seen number, depending on which meta-analysis you look at or which trial, but let's just say for hypertension treatment for people aged 18 to 60, that the number needed to treat is usually between 25 and 120. So a pretty wide range. So you might be wondering, well, Rita, what is the NNT for treating non-displaced upper extremity fractures with prescribed opioids? I'm just going to pause here for a moment and check the chat. Someone had asked if there was a sound problem. If anybody else is having trouble hearing me, please let me know. Otherwise, I will continue. Thank you. Great. Okay. So I don't know what the NNT is for treating non-displaced upper extremity fractures with prescribed opioids, but let's dive into what we do know about this evidence. And, I gave all of those caveats at the beginning about what we're not talking about in this lecture, but why did we choose this particular topic? And that's because, unfortunately, with regards to prescribing opioid medication to opioid naive patients, there's little evidence that they're any more effective than alternatives. There's evidence of harms associated with opioid prescribing, and there is no risk prediction tool that can reliably identify high or low risk patients for opioid use disorder. Some of you may remember getting this in the mail. This is a tool, an educational intervention called the Portrait, which was sent to most prescribing family doctors earlier in 2020 and 2021. And it identified for you the number of times that you prescribed a opioid to an opioid naive patient and compared that to what the average family physician in British Columbia was. It included an overview of some of the evidence as well and gave some suggestions. So let's just think for a moment, if we've got an opioid naive patient in front of us, and I'll get into the specifics of the definition in a minute. You know this already, that it can go a couple of ways. Maybe you have known somebody for 20 years and 5 years ago they slipped on the ice and they fractured something, and you gave them a small bottle of Tylenol 3s. It helped them get to bed and get back on their feet a little bit better. So that's a super successful intervention with opioids. You may also have had a patient or inherited a patient who got started on opioids for some kind of relatively minor consideration, and they just kept coming back. Or perhaps even more common, you find somebody, the famous one is women who've had babies. This doesn't happen as much anymore, but there was like this whole massive time period where women would get discharged with Tylenol 3s and then have terrible constipation, like debilitating constipation, which is the last thing you need when you've got a tiny little human trying to latch to your breast and just keep everybody in the house alive. So there's a bunch of different things that can happen. We here are using the term opioid naive to mean that they haven't gotten an opioid prescription in the last 6 months. And we do that because it's an easy way to look at administrative data. We're going to be looking at all of PharmaNet data. Usually if somebody hasn't gotten a prescription in the last 6 months, they also haven't gotten one ever previously. So it's a nice marker in the sand for identifying people who have had very, very little exposure to opioids previously. And it also, we did it that far back because it helps us make sure that we're not including people who are being treated for their opioid use disorder with prescription opioids. We used a methodology to be much more intentional about removing those people from the sample. But this was part of that. So 6 months, that's what we mean for this. So we head out, we're looking for some high quality evidence about how to prescribe opioids to non-cancer pain patients in primary care. It's a lot of P's. And this is what we find, a sucking black hole. I mean, honestly, when we look for evidence particular to primary care, a lot of the times we find sucking black holes, but in particular around opioid prescribing for non-cancer pain, it's pretty dismal. So here's what we do find. For acute pain, I like this this systematic review because it compares oral NSAIDs to other analgesic agents, and the two agents they looked at were acetaminophen and opioids. And this is for acute soft tissue injury. So this isn't necessarily our particular patient, but I know you can extend that to, which probably does have some soft tissue injury, and maybe that's what's causing the pain related to her minimally displaced fracture. But this is a pretty common thing where you see somebody come in and they've got an acute pain incident that is not something that's going to need surgery, probably doesn't even need casting. And so how do you help them get over that hump of pain? And what they found was that compared with acetaminophen, NSAIDs made no difference to pain at 1 or 2 hours and at 2 or 3 days, and may make no difference at day 7 or beyond. Compared with opioids, NSAIDs probably make no difference to pain at 1 hour, may make no difference at 7 days. And so we're left with, oh my gosh. And they also found in this study that NSAIDs probably result in fewer gastrointestinal and neurological adverse effects. So less, this is a cohort study that talks particularly about the the side effects that we might see when we prescribe opioids versus NSAIDs and acetaminophen for acute pain. And this is no surprise. I mean, constipation, way higher with opioids. Nausea and vomiting, also way higher. Dizziness, again, not a surprise, way higher. Drowsiness and weakness, also much, much higher with opioids. With comparing to our result in terms of pain alleviation, very little difference between all three agents, but much more side effects. So chronic cancer pain. So this is, I'm going to review the SPACE trial, which is this beautiful trial that was done with chronic back pain, hip or knee pain. And I'm sure that all of you in primary care have, maybe you've seen somebody today already with this particular presentation, somebody who's got a bad back, hip or knee pain that just slows them down constantly. This randomized controlled trial looked at opioid versus non-opioid therapies. And what they found, their bottom line, was that opioid medication therapy did not result in better pain-related function compared to non-opioid medication. I've got a lot of details around this. Sometimes people really like to see this. I'm not going to go through the details on it. The slides are available. Shauna, can you put in the chat how people would get the slides if they wanted them? Thank you very much. So I'm just going to go to a summary of the SPACE trial, the results. So how does pain get measured, right? Scale of 1 to 10. You've all used this before. The SPACE trial used it because it's something that real humans have been exposed to often. So they asked them, on a scale of 1 to 10, no pain to pain as bad as you can imagine, in the past 24 hours, how was it? The average in the last 24 hours right now, and the worst in the past 24 hours. So each one of those would have had a 10-point scale. And then in terms of their function, using that same 10-point scale, they look at, does not interfere with your general activity, mood, walking ability, normal work, relations with other people, sleep, enjoyment of life, or completely interferes. Right? And now in primary care, this is what we really care about. We don't necessarily care about where does it move for their pain, but can they get their life done? Can our patient get her, can she get her kids out to school? Can she get a handle on the laundry for 5 minutes, because it never lasts for longer than 5 minutes, having the handle on the laundry. And that's what we want to know. Are opioids going to help with that kind of work? And essentially what we see, let's show here with the function on the bottom of this slide, which is that for opioids, at the beginning of the trial, their number was for interference was 5.4. And by the end of the trial, 12 months later, it was down to 3.4. That's great, 2 points difference. But for non-opioids, it was essentially the same change that happened. And this was a randomized controlled trial, meaning that we can compare the two. So unlike cohort studies where there might be some confounders that we haven't been able to adjust for, a randomized controlled trial helps remove those, and we are more likely to get a really good comparison. So that sucks. It doesn't appear to help, but it might help some, but it reliably is not going to help. Opioids for chronic non-cancer pain. This is a meta-analysis which looked at 96 trials, which essentially found the same thing. Using that systematic review, though, we can calculate a number needed to treat, which I would say definitely falls into the ish category. So this is not super secure, but it gives us a bit of a perspective. So in order to move 1 point on the pain scale, not the function scale, but the pain scale, we would need to treat 8 people with opioids. So we'd give 8 people opioids, 1 would benefit, 7 would not. For physical function, we'd need to give it to 12 people. 1 person would benefit, 11 would not. And then you can see as well for role function. So how are they doing as a mom, as a lawyer, as the other roles that they have in their life? You need to give it to a lot of people, and there's a lot of people who are not going to get that benefit. Social function is a little bit better. Sleep is even a little bit better. And then number needed to harm, which is the inverse of number needed to treat, and can be really hard to calculate just because how randomized controlled trials typically report adverse events and your ability to combine those. So between 14 and 29. Risk assessment evidence. All right, so wouldn't it be great if when that patient came to your office, you could apply this tool and say, opioids are going to work for this person. Oh, but for that person, the chance that they're going to go ahead and develop an opioid use disorder or have some other complication from the treatment, that would be great if we could do that. You know, it would be great if we could do like a lab test or a screening question. And I would say that during my education, I was taught to believe that we did have tools to do this. And what I can tell you is that there are many tools, but none of them have ever proven to correctly identify the people that we are trying to identify. Our very own Jano Klimas and some other colleagues at the BCCSU did this systematic review of looking at tools to stratify risk, and unfortunately found that we were unable to effectively we were unable to identify the people that we wanted to. And so we can't figure out who's high risk and who's low risk. And so my guess would be that family doctors who have known patients for 20 years may have a better than 50% chance at figuring out who that person is. We don't have any randomized controlled trials that have done that, and that they were not included in the systematic review. But in general, and you all know this, right? You all know that you might get it right sometimes when you're guessing what a patient is going to say to you and what they're saying that they want, and then other times you're going to be like, whoa, that surprises me that they said that. And so this is just it's a further mirroring of how complicated our jobs are and how complicated patients are. So we have a bunch of gaps in the evidence. And we also have a changing landscape. We've got this practice standard that came out in British Columbia in 2016 that was very direct and very prescriptive about how many opioids you could be prescribing, what the dose was, how many you could be dispensing, and it definitely caused some ripples in the community. That being said, it has been modified several times, most recently March 2021, and it's much less prescriptive. But I know myself, I still kind of have some, there's still some resonance from that original document that came out. So we've got that playing in the back of our head. Nobody wants to get a buff colored envelope from the college that is flagging their prescribing practice. And then we also have this absolutely horrific, it's almost hard to even imagine how many people have been dying from opioid overdoses. It's just been getting worse and worse and worse despite resources that we have been investing. So this is another really important element of this environment that we are working in. And the fact that the majority of opioid overdose deaths now are due to toxic drug supply. So it's not directly related to quantities of drugs that are being prescribed by physicians. We don't really understand how do these things connect together. But it is playing in the back of our minds as we are trying to figure out what's going on. And there's a lot of work being done on this, which is great because we have too many people dying and we need to figure this out. This is a study that was just released that looked at very high level administrative data that saw a very interesting inverse relationship between prescribing and deaths. So what they saw was over time, you would see if there was more prescribing of opioid medications by physicians, there were more overdose deaths. And then that shifted. So that in this study, they found that opioid overdose and deaths were inversely related to regional prescription volume. So the availability of prescription opioids, when it went down, the deaths went up. And that is really an important signal for us to take a look at. What does that mean? How does that apply to us? So there's a lot here. There is a lot, and summing up is it's going to be tricky.
No, there is too much. Let me sum up.
Inigo Montoya won't let me advance. There we go. So we have little evidence about how to prescribe. What we do have suggests that NSAIDs and acetaminophen are as good or better. Chronic pain has a slightly higher quality of evidence, but concludes that opioids don't routinely improve outcomes, and we don't have a good tool to figure out who's going to be adversely affected. We've got this practice standard, we've got the opioid crisis, we've got the toxic drug supply, we've got new evidence that says, wait a second, decreasing prescriptions might now be part of the problem. And then you guys sent me this portrait. What the heck am I supposed to do? All very reasonable. So let's go back to our patient. Just a reminder of who she is and that we want to help her. So we're going to review the evidence, listen to what she says, and come to a shared decision. And I've included some text of a conversation that is feasible that I would be having with her. It would go something like this. It sounds like you've got a lot on your plate right now, and a broken arm was the last thing that you needed. I wish I had a magic drug, that unicorn and rainbow, to prescribe that would help you get back on track, but I don't. In fact, there's limited research about people in your situation and whether an opioid would help or not. And there's also some information that the side effects from opioids, including sedation, impaired thinking, constipation, nausea, and in some case, people go on to develop a drug use disorder. We have no way to accurately predict who that will be. The pain from your injury will continue to improve as it heals. It's likely going to be, you've been through the worst, that it's been a week now. The studies that we have suggest that the treatment that you got already, NSAIDs and acetaminophen, are really good and possibly better than an opioid would have been for you. What do you think, having all this information now? And so my patients are used to me presenting this kind of information like that, and about half of them will be like, oh, just tell me what you think I should do. And the other half will want to ask me some questions. And so my recommendation is that if she asked me for that, would be that she continue with the plan so far and offer an opportunity to check in. Now, we are going to pretend that she needs that prescription, that we decide, she's like, no, sleep is so bad. And you said that NNT for sleep was 17. I really want to see if I can take advantage of that. And so if we are going to prescribe opioids in this situation, this is my suggestion about how we do it. You need to have a clear plan, follow-up and monitoring. You need to record your intellectual footprints so that anybody looking at your chart is going to know what to do, just in case you get one of those buff colored envelopes. And this is text that I use directly in my EMR. It includes all of the elements that are in the CPSBC prescribing standard. So including rationale for the opioid prescription, expectations and goals of treatment, med safety, discontinuation, and additional treatment strategies discussed for today. I know this is a lot of text, and so I usually would have this for, it's an unusual situation when I'm prescribing opioids for acute pain. And I also have gone through a detailed college investigation about prescribing. And so I can say confidently that this kind of documentation is very reassuring to college investigators. And I just erase what I don't need. It makes it very simple for my note-taking. So opioid sparing, I just want to be really, really specific here about what we mean in this context. And that is that when opioids are indicated, you prescribe the smallest amount for the shortest period. So this webinar is not to say that you should never prescribe opioids for acute pain ever. That is simply impractical. And someone asked if they can use the EMR. EMR text absolutely would give me so much joy for it to be used. So please, yes, by all means. I think we have a separate document, Shauna. Yeah, great. Yeah, that will come with, if you put your email in, you'll get the word text as well. So opioids, we need to use them sometimes. We absolutely do. And then you want to use the smallest amount possible. You also should not be sucked into the idea that codeine or tramadol are safer. They are not. That's a whole other talk, which we can give, but you pick the one that you feel comfortable with and you do the smallest dose possible. So these are not specific recommendations of how to prescribe for acute pain, but these are examples that I found that were used in randomized controlled trials, usually post-surgery or post-emergency, and they are very similar to what I use in my practice. Which is, for example, Tylenol 3, 1 to 2 tabs, PO Q6 hours with a METE of 20, and or hydromorphone for more severe pain, PO Q6 hours with a METE of just 15. So I also give a handout. I give out a lot of handouts. Now I email them so less trees die. We've got the poll up here to see if you guys, if I managed to teach you anything during this process. Just a few questions this time though, much shorter than the last one. And I've included the link here. This one is also available on Pathways. And the bottom line, and I'm really looking forward to any questions or case situations that you guys might have to share after we go through this conclusion here. Opioid therapy is unlikely to benefit most people with acute or chronic non-cancer pain who are not palliative. That's not everyone. It's just unlikely for most people. And if you are going to try it, you want to use a sparing approach, and you want to check in and you want to see if is their function actually going back up. And if so, you want to continue to document about that. There's no way for us to figure out who's going to go on to develop opioid use disorder. And we want to reserve opioids for severe acute non-cancer pain or cancer pain and palliative pain. And again, another plug for our focus group. We'd love to be able to add to a higher quality of evidence about this topic by having you participate in a focus group, a painless focus group. As I mentioned before, in this research trial, we're also doing a quantitative analysis. We have a randomized controlled trial regarding those portraits. And we are really excited to see what happens with this education initiative. So I'd like to thank all of my team members, and I am open for questions at this time. I'd be very interested so what we discussed today, is this the same material that you've heard before, or was there anything new? And if there was anything new, I'd love to hear what that is. And you can go ahead and chat, or you can unmute yourself if you prefer.
Dr. Brasso here, Victoria, BC, Kool-Aid Community Health Center. How come I never got one of those portraits? I would have loved to have seen that data. Who made those selections?
So it wasn't because somebody didn't like you. It was because there was a inclusion criteria around how many years you'd been in practice, which it didn't have to be very long, but the period that we had to use for qualification. So I'm not sure, how many years have you been in practice? You know what, you don't need to tell me. That's an overshare on a forum like this, but you needed to be in practice for a certain amount of time. You needed to have at least 100 prescriptions that you had written in the previous 12 months. And you needed to have at least one prescription that you had written to an opioid naive patient. And so I would suspect that you working at Kool-Aid, you probably have a lot of patients with opioid use disorder who would have been excluded from the sample, and you may have shown up as not having somebody for that. But Thank you for mentioning that you did not get it and that you would have liked to get it, because that is really useful information for us going forward. We have often said, oh, well, we won't give it to the people who don't show up, but maybe we should be giving it to people who don't show up, with a notation saying your prescribing doesn't fit on here.
I think that'd be good information.
Okay, great. Thank you. Thank you for that. All right, question. What are your thoughts and experience on using buprenorphine for chronic pain management? You know what? I don't have a lot of experience, except up until very recently, I had a nursing home practice, and I had 3 patients who we tried doing a buprenorphine pain therapy, and it was through a special program that our palliative care colleagues were getting started, and the patients did okay, but honestly, I felt more comfortable with, I use what I call a homeopathic dose of hydromorphone for a lot of frail elders in nursing homes who are demonstrating signals to us that they might be experiencing pain. So that could be grimacing or crying out during personal care episodes, or it might be them saying, this hurts. And so I will oftentimes do a very short trial, like 0.25 milligrams of hydromorphone BID, and see if their behavior during those personal care episodes changes. I'll try that for a week or 2 weeks, depending on what my nursing colleagues think is appropriate, and we'll see if that works. Thank you for that question. Any other questions? I'm going to go ahead and put my email address right here in the chat, and I would welcome any additional direct emails, comments, or anything like that that you might have. Any thoughts on using opioids for acute pain in patients that are not opioid naive? Yeah, actually, absolutely. My threshold for using opioids for people who are not opioid naive is much lower. So there's been some really interesting research about increased vulnerability to relapsed or increased use of now potentially a toxic drug supply when our patients with opioid use disorder are experiencing pain. And so, you know, especially in a longitudinal relationship where you have that ability to follow up, I think that it absolutely deserves attention. And I would adjust my dose that I would be using probably pretty significantly. And I might just take a quick look at the risk mitigation outline that's on the BCCSU to remind myself, you know, is there anything particular that I should be doing about this? But absolutely, you know, experiencing physical pain in addition to mental pain that people might be treating with their opioid use disorder seems like a recipe for utter disaster. And so I would approach that with compassion and be ready to do a trial with the patient. Being really clear about what are the goals of this treatment. The goals of the treatment are to help you feel better so that your function can continue. And that might be looking after their kids. It might be making it to an appointment with their lawyer. You know, all of those things that we're trying to do. So thank you very much, Ram, for that question. I am aware of the time, and I'm going to hand things back over to Shauna and just express my extreme gratitude to all of you for showing up, and an extra special thank you to people who will be staying for the focus group, and to everybody else. Thanks for all the work you're doing and hanging in there in these super, super weird times. Thank you.